So welcome, everyone. This is the fourth community workshop of CHIP's Equitable Injectable PrEP in LA County initiative. Today's presentation is entitled Implementing LAI PrEP with Black and Latino, Latina, MSM and Transgender Women, Practical and Cultural Considerations. We are very excited to have three very distinguished speakers here. And we will first go over some of our logistics and then introduce or present our featured presenters. So we will be using the Q&A function, which on your Zoom control panel to enter any questions at any time. You can also enter any questions you may have about the presentations in the chat function as well. For those that need it, there's the closed caption option, which is the double C button, also under your Zoom control panel. So participants will be muted and videos will be disabled during this workshop. If you have any technical issues, please contact Elena Rosenberg-Carlson in the chat and she can help you with that. So next slide. So our featured presentation, we are very honored to have three local practitioners who are providing PrEP to populations here in LA County. So I'll just read from left to right. So we have Christine Gutierrez, who's a PrEP, PEP, and STI practitioner with the Care Clinic at St. Mary's Medical Center. We also are happy to have Dr. William King, who's the medical director of W. King Healthcare Group, an associate clinical professor in the Department of Internal Medicine at Charles R. Drew University of Medicine and Science. We're also happy to have Dr. Harold Glenn San Agustin, who's the HIV medical director for the JWCH Institute, Wesley Health Centers. That's a mouthful. Next slide, please. So the Equitable Injectable PrEP in LA County initiative is supported by an EHE supplement grant that has been awarded by the National Institute of Mental Health to the UCLA Center for HIV Identification, Prevention, and Treatment Services. The UCLA team consists of myself, Dr. Delara Uskup, Elena Rosenberg-Carlson, Omar Nieto, and Zuri Nzunza. Hope I got that right, Zuri. Next slide. This project is actually a collaboration between UCLA CHIPS and the Los Angeles County Department of Public Health's Division of HIV and STD Programs, otherwise commonly known as DHSP. Our community partners and supporters include Friends Community Center, Vienna Stout Human Services, In the Meantime Men's Group, and the LA County Commission on HIV. Next slide, please. So just a little bit of background about this initiative. So we've known that historically, Black and Latino, Latina, MSM, and transgender women have continuously lagged behind more privileged and well-resourced white gay male populations in receiving information about the latest HIV innovations in both treatment and prevention. As a result, these populations have not been able to benefit from early adoption of these innovations. And this has contributed to the disparity in HIV that we continue to see in these populations today. So the project seeks to address this delay in disseminating information on the latest HIV innovation. In our case, it's Apretude as long-acting injectable PrEP, or we commonly refer to it as LAI PrEP, to these populations here in LA County. Next slide. So the Equitable Injectable PrEP in LA County initiative seeks to address the delay in disseminating information about LAI PrEP to our Black and Latino transgender women and MSM. And to do this, we are implementing a series of online community workshops to provide accurate and up-to-date information on LAI PrEP-related topics that are of relevance to these particular populations, both consumers and providers that serve them. Next slide, please. I'm sure everyone knows about it, but in case there's someone who isn't familiar with Apretude as injectable PrEP, it was approved by the FDA in December of 2021, so it hasn't even been 2 years yet. It's one injection every 2 months. There's an option to start with oral tablets or go directly to the injection. And the injection site is the muscle of the buttocks. Next slide, please. Next slide. Oh, sorry. So here is the agenda for today. So we're excited to have our three presenters, but we're also excited to be able to share with you that we are doing raffles throughout the workshop to engage our participants. So our first raffle will happen once I conclude my introductory remarks. So we have our first raffle. Our first two presenters are Doctors King and San Agustin, which will be followed by a Q&A for 10 minutes. Followed by that, we will have our second gift raffle. Following that, we will go to our third presenter, Ms. Christine Gutierrez, and that will be followed by a 5-minute facilitated Q&A. We are reserving time for evaluations of the webinar. This is the only kind of data that we collect, and so it's really important that we have people stay on the line to complete these evaluations. And an important part about completing the evaluation is that once you've completed it, you will be directed to enter your name and email for a chance to win one of 3 $50 electronic Visa gift cards. Once we've completed the evaluation and closing remarks, we will end the webinar with our third gift raffle. Okay. I think we're ready to move on to our presenters. So our first presenter is Dr. William King.
Good morning. Let's see. I need you to, there you go. Great. Can everybody see my slides?
Yes, we can.
Fantastic. Good morning, everyone. And thank you for the invitation to be here on this panel. And Harold and I are on the commission together, and I don't know Christine, but hope to develop a relationship with her after we start speaking. But it's an honor to be here to speak with you. These are my disclosures. My career has also changed from being a 95% researcher and 5% clinician to now in private practice, I'm 95% clinical care and 5% research. So the information I'm going to present to you is not my own independent research, but a synthesis of literature review and my lived experience as a primary care doctor and HIV specialist. So let's lay the foundation. Let's see why there's a need for an equitable distribution of this prevention tool, LACAB, especially within the African American community, my community. I also use the terms LACAB and aptitude interchangeably. This data from the CDC was presented at CROI in 2022. While there were improvements in total overall risk, lifetime risk of an HIV diagnosis among men, there are still stark differences in lifetime risk of HIV diagnosis as stratified by race and by gender. Now, you guys might be a lot smarter than me, but when I first saw this slide, it was a little confusing, especially the table. But the higher the number at the bar graph, so if you see there's 27, 50, 89, the lower the lifetime risk. So we see that the lifetime risk of an African-American male at 1 out of 27 has a higher lifetime risk compared to their racial and ethnic counterparts. This is much different than in 2016 when it was 1 out of 2 for African-American BSM, Black males who have sex with men. Still, there's a dramatic difference between African-Americans' lifetime risk of 1 out of 27 and Caucasian males at 1 out of 171. If we go to LA County surveillance data in 2020, it demonstrates that although African-American males are 4% of the population, Black males are 60% of persons living with HIV. Remember that in LA County, most of the new cases of HIV acquisition is attributed to male-to-male transmission. Now, oral PrEP, or pre-exposure prophylaxis, as mentioned by Dr. Brooks, emerged in 2012 as a powerful biomedical prevention tool, and when taken consistently, and that is consistently more than 4 times a week, reduced HIV transmission in MSMs by 99%. So 99% of these numbers were so compelling that it seemed like an easy equation. It's a highly tolerated and effective medication to patients who are at high risk of HIV acquisition. It did not require a special prescription, so providers, HIV providers, primary care providers should be able to prescribe it. So our thoughts were willing patient, willing provider, equals PrEP in hand. But we learned as clinicians and in the public health sector, and many of you out there, this is not as easy as we thought. Sorry. I have to admit that I was one of the reluctant providers at first. My population of African American males also may have hypertension, they have diabetes, they may smoke, they may have a genetic disposition to kidney disease, and all these factors can impact the kidneys. At that time, oral PrEP was Truvada. It was known to impact, although small, that impact the kidneys. I was not aware also of that time really of a subgroup analysis of the impact of Truvada on African American men with renal disease. So initially I was reluctant, and I said that on a panel before. However, the data of the power of oral PrEP and the continuing increase in racial disparities in HIV incidence made the benefits for being on PrEP for my patients far outweigh the risks. And I became an advocate and a prescriber, which I continue to be today. As we see here in this table, I may not have been alone in my initial reluctance. This data from 2017, from a 2019 CDC report, showed that despite the efficacy of oral PrEP, this is years later, there was a PrEP cascade of care. What I mean is that if you go across from left to right, you don't see that all the bars are equal. There's a cascade of care that showed a dramatic drop across race and ethnic lines, from PrEP awareness to PrEP discussion with a provider to actual PrEP use. What sticks out for me is that even after controlling for health insurance and having a usual source of care, these are traditional barriers to access to a medication or access to treatment. White MSMs who discuss oral PrEP with their providers were significantly more likely than Black MSM to use PrEP. So something is happening with the Black male MSM population, particularly with regards to PrEP utilization. Although Black people, not just MSM, accounted for 40% of new HIV diagnoses, there are approximately 14% of PrEP users compared to their Latinx and white counterparts. This chart from AIDSView demonstrates PrEP utilization by race. We see on the graph on the left that although there was an initial slow uptake of PrEP, like in 2012 and 2014, use over time, there became a rapid uptake of PrEP over time, regardless of race. But when we look at the graph on the right, the PrEP to need ratio, the number of PrEP users divided by the number of new diagnoses in a year, we still see uptake. But notice there's a starting separation between the Black individuals represented there with the blue line and their racial counterparts. Black individuals have the highest PrEP to need ratio, demonstrating that PrEP is not only highly underutilized, but there's a greater need for utilization in the African American community to combat the continuing high incidence. So we have seen that Black persons, and particularly Black MSM, know about PrEP, but don't discuss PrEP with their healthcare provider at rates similar to white MSMs. And this is despite a growing need for PrEP within our community. We see it in the literature that reasons stem from medical mistrust, to being unresponsive to targeted marketing, which undeniably are important reasons, but can lead us not to push further. To resign ourselves that this is a truism, that African American males, African American men who have sex with men, are not going to be responsive to this as well. But I counter that's the problem, that the message is important. What we are telling our Black MSM patients about PrEP and our clients about PrEP, how we are telling them, and I dare say who is delivering the message. Now, HPTN 073 was an elegant study that demonstrated just that. And an open-label clinical trial offering Truvada to Black MSMs with culturally appropriate risk counseling and adherence support. The results were outstanding, as you see here. 226 individuals were enrolled, 86% of them self-identified as Black or African American, 79% started PrEP, and 64% remained on PrEP at week 26. Of note, 073 had a cadre of vested African American researchers. The intervention there seen in the middle, C4, acknowledged intersectionality within its design. For those who don't know, intersectionality started off as a social justice term coined by Kimberly Crenshaw, a legal scholar and the pioneer of critical race theory. It recognizes that the challenges and stigma of racism, homophobia, and genderism impact Black males who have sex with men at the same time, and should be addressed as an additive. So each of those layers, homophobia, racism, genderism, each of those layers are additive and should be studied and addressed as individuals, right? Not as individual challenges, excuse me. So be addressed as additive and not as individual challenges. So in 2021, we have Apretude, which is shown to be so effective against the gold standard of oral PrEP that the studies were stopped. But we changed from a daily oral tablet to initially monthly injections and now bi-monthly injections with an impressive sized needle. And those of us who've delivered the medication know that that's 1.5 to 2 inch needle. And we changed from self-dosing, which we're providing PrEP within the hands of the patients who can take it at home, take it on their trips, to relying on doctors' offices for PrEP. But it seems as the message to the clinicians is still the same. It's a wonderful medication, does extremely well, but have a willing provider, willing patient, and receive the medication. So why are we expecting a change? But the message is getting out about LA PrEP to MSM of color. This is the 2023 abstract presented by Dr. Tony Potate of North Carolina, who demonstrated that Black and Latinx MSMs had a higher LA PrEP awareness. So if you look there in the middle, right here. So the dark bar there is awareness of LA PrEP prior to the survey. And they had the highest overall rate of being interested in PrEP after a brief conversation. Now, this was an abstract, so I don't know what the conversation was, the details of it. But you see there's an interest, there's a knowledge about PrEP going into this study, and LA PrEP going to the study. And actually, after a conversation, there was a greater interest in LA PrEP. So men of color are interested in LAI PrEP, but will they adhere? Which is very important. I'm sure, as Christine will talk to you about, very important in terms of when we're prescribing the medication is adherence. Dr. Hyman Scott of San Francisco Department of Public Health and UCSF, we recently presented at CROI this year a subgroup analysis of HPTN 083. This is my summary slide of the presentation. 083 was successful in its design to enroll a large enough trial population of Black MSMs that were able to do a subgroup analysis. Usually the numbers are small in clinical trial data, and we can't do this type of analysis. So there were there were a total of 1,573 individuals. 844 of them were U.S. African Americans, and 92% identified as a Black male who had sex with men. The results: CAB-LA had a protective efficacy as compared to tenofovir of 72%, compared to oral PrEP with high adherence, which is real important. The high adherence and on-time injections are greater than 80%. So yes, this is a clinical trial where the meds are supplied, and also I'm sure there was a vigorous support. But the message that I am getting, is that Black men are not only aware and interested in LAI PrEP, they will adhere to the time injections, and will have great preventive outcomes as expected. So let's get this medication to our clients and our patients. Again, in my mind, it's not just that simple. Keeping in mind intersectionality in our current dysfunctional healthcare system, there are multiple layers that create barriers to getting Apretude in the arms of our patient, as represented there by the orange circle. There are patient-level barriers, stigma, and although there are other ones, stigma I think is one of the most pressing ones, which can manifest itself in the expectation of a poor outcome or experience at a healthcare system. Black persons and Black bodies have been under a healthcare system where racial injustice and inequities in care have existed since enslavement. These personal and witnessed experiences of inequities negatively impact our trust and willingness to go to providers. When we add on the stigma attached with sexual health, homophobia, genderism, the potential perceived and experienced stigma multiplies. For network barriers, insurances create barriers. Most of my patients have employer-based insurances, which could change the next year, affecting their ability to see me or create new barriers and receive an Apretude. I've personally talked with medical directors of some of these insurance companies who would also create barriers because they compare the high cost of Apretude at $26,000 a year to the less costly generic Truvada around $600 per year. As one medical director said to me, why can't they just swallow a pill? There are also hidden costs, including co-pays for clinic visits, medication, and labs. And we have to be responsive to these kind of hidden costs to let our patients know so they're not surprised. But other healthcare system barriers, we have a tough time already finding culturally conscious primary care providers prescribing oral PrEP. How do we develop this cadre of knowledgeable and willing providers to prescribe, change their workflow? And I'm sure Christine will talk to you about this as well too, and provide aptitude. So this is my strategy. The first thing overall, and it seems simple enough, but the first thing overall is to build trust. Now we have seen that there's awareness. We have seen that there is interest with education about LAI PrEP or Kappa-2. We have seen efficacy in HIV prevention and adherence to on-time injections, excuse me. But we have to build trust. Trust is, I think, is the essential thing if we're going to try to get any individual, particularly Black men and cross-sexed men, into our clinics, in order to get people like individuals within our offices. Building trust is not automatic. It is an organic process that can ebb and flow depending upon the situation. We as providers must be vested in creating this type of trust, which means that you must be vested in the community, especially the Black community. You must be seen, not your centuries, not your flyers, not your emails, etc. You must be seen. You must support the community. You must align with CBOs, and many of the CBOs that are part of this collaboration to provide this project, I've worked with before in the past, but you must also not only align with them, you must build respectful, mutual beneficial alliances, because gaining their trust is important for us to work together and to provide the best care to their clients. You must be accountable. When I discuss Cabenuva, I know that's the treatment, that long-acting injectable treatment for HIV, not the prevention, but I let them people know that I'm a paid speaker. Right? I disclose that because I don't want anybody to think that I'm pushing my agenda and their agenda may not meet. If I or my team make a mistake, I own up to it and I apologize and I try to make the patient whole. On the patient side, at the same time, they must understand that we are human and that we can make mistakes. So patience is also very important. We need to also use our home training. What I mean by that, I use people's last names. Even if they are younger than me, once I find out their pronouns, I use their last names as out of respect. I tell them what I am doing during examination, ask for permission before touching certain areas that could be leading to triggers. For example, I don't know, you guys can't see me, but I'm 6'2", I'm an ex-football player. If I'm coming to palpate the thyroid, I make sure that people understand that. When I'm doing the examination, I let people understand exactly what I'm doing. We recognize that trust should not be assumed because of shared experiences, our cultural gender attributes. Just because I'm an African-American man, I should not assume my patients who are Black MSMs will automatically trust me. I still have to willingly earn that trust, and it's something that I work at with each patient as well. And most importantly, despite all your efforts, trust can be easily lost. So this is a constant organic thing to build this culture of trying to build trust within our interactions with our patients and our potential patients. How do we do this? We try to be trusted and willing messengers. I realize that being in private practice, I have certain advantages than being in an FQHC or a large group practice, especially when it comes to creating an office culture. However, this is one of the reasons and one of the benefits and one of the things I enjoy about being in private practice. The first step is the office clinic. My litmus test towards any office I step into, as a patient, as when I bring my mom to the office, my wife, my kids, my friends, if I'm there, I want to see what I want to be a patient here. But I want my family to be patients here. Do I see myself represented in the office, my culture as well? Not just a flyer on the wall or something like that, but when I walk in, do I have that feeling that this is a place I feel comfortable at? The front office, this is very important. This could make or break patients wanting to come to the office. Again, it helps to have people well vested in the community. And many of my office staff are vested in the community. They live in the community as well. The front office needs to recognize and anticipates that intersectionality that we talked about earlier. There are barriers facing Black MSMs. There may be a perception and belief that they have stigma because of their prior experiences with our offices. And we want to intervene when appropriate. We want individuals to realize that they're safer. This is a safe environment. Patient providers, many Black men, not just Black MSMs, have not been to a doctor in years. I had a patient yesterday who had not been a doctor for several years, for 7 years as well. Many are seeking a Black doctor for their care. They ask their insurances now. Many Black MSMs are looking for a trusted medical home. We could be that home. All of us can create our environments to be that home. It's making sure that your clinic culture, and it's one of those ways of becoming that medical home. Understand why the patient is there. If they're there for, and this is something that took me a while, because when I was becoming a PrEP provider and becoming an advocate as well for PrEP, I almost proselytized. Everybody has to be on PrEP. But if they're there for primary care, you can incorporate risk reduction during your sexual history taking. If they're there for an urgent care matter, I don't press on PrEP. I'm trying not to make my agenda their agenda. We're working together with shared decision making. If a patient is there to get their blood pressure checked, I do the blood pressure check. If they're there for an STD or an ED medication, then this is creating an opportunity for me to discuss sexual health and to discuss PrEP. We can create current touchstones. This is very important because the more touchstones you have of our patients, the more we can develop a trusting relationship. We can take care of the whole person. And that's my agenda and my goal, is that when I have PrEP visits, I try to create environments that they feel comfortable in. I can take care of the totality of the patients, not just for PrEP. And not just to be a checklist for PrEP either. I want to make sure that they're screened for diabetes. I want to make sure that they're getting their well-visit checks with vaccines if necessary. I want to make sure that they're getting their screenings for colon cancer because the age dropped down as well. We want to take care of the whole patient. So we're normalizing PrEP as part of the process. This is if they're going to take a diabetes medication or a hypertensive medication. This is part of the process. This is part of me making sure that you're getting quality whole care. And sometimes we take a hit. And this is one of the benefits of being in primary care. Insurance changes. We have non-reimbursable actions such as letter writings, prior authorizations, continuing care during insurance changes. During COVID, lots of people lost their insurances. We still provided medication for them. When patients are making their changes of insurances, we still do continuity of care, even though we know we're not going to be reimbursed. Because the important thing for us is to make sure that the patient is well taken care of and to continue to maximize their care, be they living with HIV or be they at risk for HIV. So in order to meet the goals of decreasing racial disparities in HIV incidence, we have to close the racial gap in PrEP utilization. Because Black males MSMs and white males MSMs, we have to close that racial gap. PrEP could be an effective modality to do this, but it would require an authentic, culturally conscious healthcare team vested in improving Black males without sex with men's overall health, respecting patient autonomy and decision-making, particularly shared decision-making with regards to their healthcare, advocacy to improve these nuances in insurances. We had to find ways in terms of eliminating or subsidizing these hidden costs, which could create the barriers in themselves for individuals to have this modality. And most importantly of all this is trust building as well. I thank you for the time, and I thank you for listening, and I'm open to any questions.
Thank you, Dr. King. And for attendees, if you have any questions for Dr. King, please enter them in the Q&A or in the chat function. So our next presenter is Dr. San Agustin. Same with him. If you have any questions, please enter them in the chat or the Q&A.
Good morning, everyone. Thank you so much to the organizers for allowing me to speak on this platform. Specifically, I'm going to be speaking about implementing long-acting PrEP with our Latino MSM and transgender women patient priority population. Okay, so by the way, really great portion of the workshop from Dr. King. That was my first time hearing from Dr. King, and that was just amazing. So thank you for that. Difficult to follow, of course. Okay, so we'll start with a little bit of statistics here. So this is from the CDC looking at HIV incidence, so new HIV infections in the United States from 2010 to 2019, disaggregated by race. Let me put my pointer. So we can see here consistently since 2019, Black and African American men who have sex with men have been the highest risk category with regard to acquiring HIV. During that same time period, we saw rates of HIV decline among white men who have sex with men, and we saw those same rates increase among Hispanic and Latino MSM. So this is a very important conversation that we're having today because we want to see how we can potentially affect and shift this trajectory with this focus on these two priority populations. So specific to HIV and Latino MSM, as of 2019, we know that there's about 1.2 million people who are living with HIV here in the United States. About 290,000 identified as Hispanic or Latino, and we know about 85% of those folks were actually aware of their HIV status. With regard to incidence, around 35,000 new infections per year in the US. That was as of 2019. Of those, about a quarter were Hispanic and Latino men. And among the Hispanic and Latino men, about 85% had the risk group of male-to-male sexual contact. So that still predominates, just as it was for Black and African American men. Just as it is, Hispanic and Latino men had the highest risk category for male-to-male sexual contact. We'll go into a little bit of the need for PrEP in this priority population, but we know that only 14% of Hispanic and Latino people who could benefit from PrEP were actually prescribed PrEP. And this is lower than the overall number, which is 23% who were eligible for PrEP who were prescribed PrEP. So some of these inequities in PrEP coverage and PrEP uptake are demonstrated here. So we know that significant inequities in PrEP coverage exist based on race and ethnicity. That was shown. We know that low PrEP uptake in Black and Hispanic people are compared to white people. So this is the graph on the left here. Overall, we know that 25% of the people who have an indication for PrEP here in the US were actually prescribed PrEP, and that's across the board, across all races. But when you disaggregate by race, we see here that only 16% of Hispanic and Latino people were prescribed PrEP. This is a far distance from the EHE goal as of 2030 for a 50% PrEP coverage. So the discussion today around long-acting PrEP is really going to be interesting, and where in the next 10 years or so, we'll see, are we going to be, is PrEP going to be a little bit more accessible to folks who are Hispanic or Latino? That inequity in PrEP is also demonstrated in these two graphs here. When you look at the proportion of folks who have a new diagnosis for HIV disaggregated by race, and the difference of those folks who are prescribed PrEP. So when you look at the red bars here, making up a large part of our new HIV diagnoses every year, and a smaller proportion of that were actually prescribed PrEP. Dr. King talked about the PNR, the PrEP to need ratio, which is your prescriptions of PrEP divided by the indication of PrEP. This just is an abstract that was presented at AIDS conference last year. This looked at the US geographic regions, Midwest, Northeast, West, and the South. And across the board, we're seeing here the differences among Black, Hispanic, and white in terms of how much PrEP is needed in that population, and how much PrEP is actually delivered to that community. So when you look at Hispanic as a group specifically, we're seeing that consistently here below the green line. And then just one final note on disparities in PrEP, and this was a cohort from the Kaiser Permanente system. So they have a large number of folks who are receiving PrEP. When they looked at certain demographics, so age, race, and gender, they found that Latino folks, as compared to white, were less likely to be prescribed PrEP. They were less likely to initiate PrEP, and they were more likely to discontinue PrEP. So, there's a lot of factors that play into why it is that we're not, delivering PrEP to this high-risk patient population. There's a lot of structural and systemic factors to consider, and there's also some individual factors to consider. So I listed some of those here. So this is specific to what are our challenges that we face today in delivering some of the prevention messaging to this priority population. Similar to other racial minorities, we see a lot of racism, discrimination, stigma around HIV and homophobia. We see higher rates of poverty, lower educational level, and language barriers. This is something that I'm sure a lot of us see every single day as factors that lead to decreased access in certain services such as HIV testing, HIV treatment, and prevention services. We know that a significant portion of new HIV diagnoses are coming from folks who are unaware of their HIV status. So we really want to try to get those who are living with HIV to be aware of their status and to get on treatment to be undetectable. We also know that other STIs might increase the risk of HIV, and so we want to increase testing and maybe increase the messaging around STI prevention. Immigration status. So we see this a lot in clinical practice. So patients are probably going to have some trepidation entering into our healthcare system if they are undocumented in the United States. They might, fear disclosing their immigration status and therefore avoid seeking HIV services. And this, Dr. King talked a lot about building trust, and it's so true as well for Latino men who have sex with men, is there's a general mistrust of the healthcare system, and that mistrust can reduce the likelihood of them engaging in our healthcare system. Okay, so I'm going to pivot now to just a few slides on HIV and transgender women. So we know transgender women are disproportionately affected by HIV. HIV prevalence among transgender women is 14%. And when you look at specifically Black transgender women, we're looking at an HIV prevalence of 44%. Okay, so I'm gonna skip that one. With regard to PrEP and transgender women, it's been shown that there is a general high awareness about PrEP among transgender women, but actually low utilization. So there's a huge gap here where we know about 92% of transgender women who were surveyed were aware of PrEP, but only 32% of them were actually engaged or are using PrEP. So we want to try to close this gap a little bit. It would be interesting to see, and we're seeing this in practice, is, would long-acting PrEP be a mechanism or a vehicle to have more transgender women engaged in PrEP? Okay, so among transgender, I guess of the estimated new HIV infections in the US in 2019, there were about 35,000. 2% of them were among transgender women. And when you break that 2% down by race, 46% were Black and African American, 35% were Hispanic and Latino. Okay, so several barriers come up when talking about PrEP uptake for transgender women. Divided here as well are individual factors, interpersonal community factors, and structural and systemic factors. So at the individual level, there are concerns about cost. There are other competing priorities for the individual, mental health concerns, substance use. Let's see, the concern about adverse events related to PrEP. And maybe there's some misconceptions out there, but there's potentially a concern about a drug-drug interaction with their feminizing hormone therapy, or gender-affirming hormone therapy, which there isn't, of course. Within interpersonal and community factors, so there's HIV stigma, patient-provider communication. All these things kind of play into maybe some trepidation that a transgender woman will engage into prevention and PrEP. So I won't go into that too much. Okay, but this is the one I want to go into, which is, we know that there is a high PrEP awareness among transgender women, but we're seeing that only a small percentage, 32%, are actually engaged in PrEP. And so these are some of those reasons why we're seeing some prevention challenges. Transphobic discrimination or transphobia. HIV stigma may prevent transgender people from learning their HIV status, so maybe reluctance to engage in HIV testing. There's racism and discrimination may increase HIV risk-related behaviors and lead to health disparities in HIV. Transgender and other gender minority youth may be less likely to engage in HIV prevention and treatment services. So we see this a lot in practice every day. We're probably going to need multi-level interventions to address these disparities. And most importantly, I think if given an option, or if forced to choose, a transgender woman is always going to pick their gender-affirming services over maybe HIV services or HIV prevention. So if you are not meeting the need for gender-affirming services and gender-affirming hormone therapy, then we're probably we're going to need to address these issues before we can start to talk about HIV prevention in this priority population. Okay, so some of these misconceptions are listed here among transgender women. For any PrEP option, as I mentioned earlier, there's a concern about drug-drug interaction with gender-affirming hormone therapy. Maybe there is a misconception that an injectable PrEP is difficult to get. This is we try to promote or educate our communities about the availability of injectable PrEP, and we work alongside our PrEP navigators to look for ways to try to get injectable PrEP as an option for folks. It's not always going to be an option depending on insurance, but many public insurances now are allowing or approving injectable PrEP. And this is something that comes up often. Some of my patients have some silicone implants or fillers in their gluteal area, and so there's a concern that maybe injecting injectable PrEP in that area would either mess with their implants and fillers. So we try to navigate around this misconception by saying, we can always find a different spot around the same area, maybe pushing the implant over so we can inject into that area. But there's a lot of ways to kind of address some of these misconceptions, and hopefully you're comfortable enough to have some of these conversations with patients to address some of these misconceptions. Okay, I want to share a little bit about my experience in the clinic in offering and providing long-acting injectable PrEP to these two priority populations. Specifically, this is one patient that I had who we tried him on generic and brand name Truvada. We tried him on Descovy. This is a Latino MSM individual. He could not tolerate any of them, any of the oral PrEP options due to side effects. He had really severe nausea and vomiting. And so, every visit, every 3 months, we would do the panel as if he were taking PrEP. We would do HIV testing, we would do STI testing, we would do prevention counseling or risk reduction counseling. But there was always this worry that he would seroconvert because he wasn't he wasn't taking PrEP. Soon as long-acting PrEP became available, we told him about it. Immediately, he jumped on the opportunity, and he's tolerating it well. So this is, potentially something that was really life-saving for him, where he wasn't able to access PrEP before, and now he is. So we have, I didn't list it here, but I have another couple. These are two Latino MSM patients. They're a couple, they're with each other. One of them I remember has a huge fear of needles. And when he first came into our clinic to access PrEP, LAI PrEP was not available at that time. So we were offering him oral PrEP. We went to draw his blood, and he actually fainted in our clinic. So so in this couple, one was very fearful of needles and the other one was not. So when long-acting injectable PrEP became available, the one who was very afraid of needles definitely stayed on his, he said no to LAI PrEP. He wanted to stay on oral PrEP, but his partner, for the convenience of it, wanted to switch over to LAI PrEP. So we're going to see differences in terms of preference, whether oral or injectable PrEP. But the main thing is that it provides an option. Let's see. So some transgender women actually tell us they want to be on LAI PrEP, but we also tell them about, the clinic appointment schedule that is, it's going to be every 2 months. They come into the clinic, we draw their blood, we give them their injectable. Very different from what we were seeing from the clinic schedule for oral PrEP, where they would come in every 3 months for labs. So some transgender women, even though they would prefer or would rather be on long-acting PrEP, they actually choose to stay on oral PrEP because they couldn't make it to that clinic schedule of every 2 months. For several reasons. A lot of, some of our transgender women patients do also commercial sex work, and so that lends to very sporadic availability. Maybe they're traveling for an extended period of time, etc. In preparing for this presentation, we actually put just a very brief survey for our patients just to understand what they like about being on Apretude and what they don't like. And so I listed some of those responses here. So there was a theme across the board, and we'll show that in the next slide as well. But some of the things that our patients reported that they liked were that there were no pills, no stomach pain. They didn't have to remember to take a pill anymore, so not forgetting was a like. They liked the idea of a prevention from HIV. They liked the idea that it was long lasting. Oh, okay. I'm gonna, in the spirit of time, I'm gonna go a little bit faster here. Okay, so in HPTN 084, there was an open label extension for product choice. So we saw that in 084, 78% of participants chose long-acting cabotegravir over oral PrEP. And I'm going to summarize this in this slide. So some of these reasons, 78% of those who chose cab prefer injections and they don't like pills. Versus, majority of the people who wanted to stay on pills just said that they preferred pills and they didn't like injections, which is what we were seeing with some of our patients. So this kind of puts together those main slides that I was going through, which are the prevention challenges among Latino MSM, prevention challenges among transgender women, and the, what patients like and what are the benefits of long-acting PrEP. So to address HIV stigma and discrimination that was present in both populations, one of our patients said this was a convenient option, it's long-lasting, it's effective. So this, this maybe removes some of those barriers. They're not, so it'll remove some of those barriers. The barrier or prevention challenge around racism and homophobia and transphobia, LAI PrEP we know is discrete. Maybe decreasing access to HIV testing, treatment, and prevention services for both. Some of the responses were they were not forgetting to take PrEP tablets anymore, so they don't have to worry about not being covered. It's easy, it's worthless, it's manageable. In 084, some of them reported that it was convenient and it's easier for adherence. To address the prevention challenge of medical mistrust, data did show that cabotegravir is superior to oral PrEP. That was what was reported in 084 in the respondents of the 084 open label extension. No pills, no side effects. Those are great because, you know, if we're offering a product that doesn't cause side effects, then it's going to help support the trust in our healthcare system. The prevention challenge about immigration status or unmet need for gender affirming care, you know, we're offering a choice, an option for our patients, for those who prefer to have injections. And also among transgender women, we can actually couple some of these injectable cabotegravir or Apretude with their hormone injections as well. So maybe combining the two. And when you look at kind of like a global perspective or a national perspective on how we're going to be addressing PrEP and PrEP uptake, we're going to need, you know, community-based education to providers such as this workshop, but also maybe, you know, opening that up to community-based discussions to raise awareness. We want more kind of culturally sensitive and relatable healthcare providers for a trusted community source of knowledge. We want to combat misconceptions and unfounded beliefs, specifically maybe about risk compensation, this perception about decreased risk while being on PrEP. Let's see, we want positive messaging across social media and social networks to improve the knowledge and attitudes and reduce stigma. And we want to support each other with prevention messages for HIV and STIs through monitoring and testing.
Great, thank you, Dr. San Agustin. Great presentations, both of them. So we are going to go ahead and take some time for question and answers. And I know Elena has been monitoring both the chat and the Q&A for questions. So do you want to start us off, Elena?
Sure, absolutely. I also just want to thank you both so much. Very, very informative presentations. We've gotten a lot of claps and thank yous in the chat. So hopefully you're seeing those. We do have some great questions coming in. The first is just a clarification on side effects. So are the general side effects of injectable PrEP, aside from soreness at the injection site, similar to daily oral PrEP?
I can answer from my perspective. You want to answer as well? Okay. So yes, there are. So yes, Harold had talked about the issue of site reactions and pain. Sometimes they get nodules as well. But one of the things the package insert mentions that I continually forget is that there can be exacerbation of depression.
It's true.
Right? So I think that's something that we have to monitor, and I forget that because I'm so happy to give the injection. The patients are happy, but if somebody has a history of depression, we can do that. We have to be conscious of that.
Yeah, pretty minimal adverse drug reactions, both to oral and injectable PrEP. There are different mechanisms of action. Obviously, we won't see the GI side effects from the injectable PrEP option as we were seeing with Truvada specifically, the startup syndrome. But yeah, I would say across the board, very minimal side effects. And if there were, it's just mostly the injection site reaction that was mentioned in the question.
Thank you. Our next question is for Dr. King. The question is, Dr. King, in your practice and experience, do you find it challenging to reach out to the younger generation, specifically 18 to 30-year-olds?
Yeah, that's a great question. My practice is probably more than 25 and up as well too. I'm open, but I think there are certain barriers. I mean, I got a gray beard and other things as well too. So that's where I think collaboration comes in, and working with other organizations that work with that risk youth. I would welcome that. I remember when I first started out, there was a person named Richard Hamilton who would come when I was working at THE, would come and actively bring clients into the office and sit with them, to make sure that they're going to their appointments, that they feel comfortable. I'm willing, if somebody wants to bring a patient to me about that age group, I'm willing to meet them to find out, is this the right office for them, right? A lot of times individuals that age are going to be on their parents' insurance. And so we want to be able to make sure that they feel comfortable, not just because the parents chose me as provider, but they feel comfortable coming to me. So I'm willing to do that, to have that meet and greet before they decide upon who they want me as a provider. But I'm open to it. My nephew works in the front office. He's about 19, 20. He keeps telling me I got to get on Instagram. I got to do all these things. And I'll have to have him do it. I mean, we have websites. We are on all the PrEP navigator components. We're on all the locators. But getting that targeted population to come in, even though I'm here in this area and to cross from the Crenshaw Mall, is a little difficult.
I think we have time for one, maybe two questions. The next question, Dr. San Agustin, this question came in during your presentation. I'm curious to know how you are addressing injectable PrEP for people who have gluteal implants. I think you spoke just briefly to this, but can you share a little bit more information on that?
Yeah, so this has come up ever since we started offering long-acting injectable PrEP. So so before I go to the gluteal implants specifically, so I'll talk a little bit about the needle size. So it's actually recommended to use a longer needle size for folks who have a higher BMI or maybe just higher kind of gluteal fat. So what we were seeing actually initially is when we weren't using the longer needle, perhaps we were actually injecting into the fatty space rather than the intramuscular space. And so what this came out to was patients were complaining that their nodule was lasting for a really long time, maybe past a week. Whereas maybe, it should only be lasting about 3 days, if any, if they have a nodule. So if we were to, for anyone with a higher BMI, and we start to ask, how long is your nodule sticking around for? We might start to ask, are we using the correct needle length? Because maybe we needed to use, and unfortunately in the kit, they don't come with the longer needle length. It comes with only one needle length. And so you have to kind of look throughout your clinic to find a longer needle. So that's really important to ask is, how long is the nodule staying there? Because if it's staying there longer, perhaps you're injecting not into the intramuscular space. And then specific to nodules, obviously we don't want to massage the area, just maybe cool compress, warm compress, Tylenol just for the pain. For both folks who have a larger mass in that area, whether it's from, subcutaneous fat or from injections, we try to push. So basically, we don't ever want the patient we're injecting to be putting weight on the side that we're injecting into. So we actually have them either, if they prefer to stand, we have them lean over on the opposite side. But sometimes we have them actually, lie down prone on the table, and that'll relax the area. And so if they had a gluteal implant, it will kind of just fall over to the side. And so in that case, what we do is we, sometimes it's a two-person team, sometimes one person can do it, but we need someone to kind of push up and towards the middle, and then we'll inject into the ventrogluteal side. So hopefully that helps. But we, obviously we definitely don't want to inject into the implant or areas of fillers. We want to go straight through the fat and into the intramuscular space.
Thank you so much.
So, Elena, I think that's it for the questions. And Dr. San Agustin, thank you for answering that question. I know that from our earlier presentation, the implants and fillers were thought to be a factor that would exclude people from being able to do injectable PrEP. So I think people on this call or in this webinar are learning something new about that misconception. All right, so thank you both. And I'm sure people will continue to add questions. So if you can just stick around and we'll deal with additional questions. So we have a raffle. I missed the first raffle, but it was done behind scenes. So we have a raffle. Elena, do you want to tell us who our second raffle winner is?
Yes, I just spun the wheel and it is Juliana Soto. So congratulations, Juliana.
Congratulations, Julianne.
And we'll
So
follow up with you in the chat.
Yes. Elena or Omar will follow up with you. All right. Thank you both. And now we're going to move on to Ms. Gutierrez, who will be talking about some of the practical considerations in implementing LAI PrEP in a clinical setting.
Hi there. My name is Christine Gutierrez. I work at the Care Center in Long Beach. And I'm going to be talking about the practical considerations in implementing long-acting injectable into your clinic, as well as some of the practical implications that are involved in order to get patients, just different things that you do need to discuss with your patients. And let's see, so just as a very brief background, it's the Care Center. We're way over in the corner of LA County in Long Beach. We do PrEP and PEP services. We started to actively do PrEP in 2016, and we got our first injection into, I'll say arm, but we know it's not an arm. We got our first injection in February of 22. So we pretty much jumped on the long-acting injectable. Okay, one of the things that I do notice that when you do talk about long-acting injectable PrEP is, of course, like Dr. San Augustine mentioned, they want to know if it's covered. Okay, they assume that it may not be covered. They don't have insurance. They may even be undocumented, and if they're undocumented, they just assume they're not going to be covered. So I discuss that. I discuss that Medi-Cal covers it. If they do not have insurance, regardless of their documentation status, let's see, sorry about that. Regardless of their documentation status, state of California will cover it. So I discussed that with them. There's something called PrEP app for those of you who are not familiar with it, but PrEP app will cover it. And it's something that the state of California will pay for the labs, the visit, and then ViiV will cover the medication. So after they may, at this point, be interested in starting PrEP, the next thing I want to do is discuss the option that you have a choice. You could either do pills every day, or you can do the injectable. And if they, of course, are interested in injectable, at this point, I discuss the side effects, the efficacy, etc. Okay. The second thing to consider that you really do need to consider is this going to fit into your lifestyle? And that was something else that the just previous speaker spoke about, was they may not be able to get to your clinic every 2 months. So I've had the instances where they like it, they want to start on it. You tell them, okay, you need to, et cetera, et cetera. The first one, it's going to be a month apart, then 2 months apart. And then they call you up and they say, you know what, I'm having trouble getting off every 3 months. I really don't think I'm going to be able to make it every 2 months. Or like has been mentioned, they might travel out of town. They might be flight attendants. Teachers also can't take that much time off. My teachers on PrEP typically come perhaps every 4 months, sometimes every 5 months, just because of the fact that it's very difficult for a teacher to get off. So discuss the timing of the injections and really see if it is going to fit into their current lifestyle. Okay, the other thing is, okay, so they want to start on the shot. However, it's not going to be right away. If they have Medi-Cal, we have to get a prior auth in order to get the injection, and that usually takes about a week and a half or 2 weeks. That's not a big problem, week and a half or 2 weeks. Okay, we need to verify their benefits depending on what their insurance is. And if they are going to be on the ViiV Connect, the patient in assistance program, we have to enroll them, and it's going to take about 2 to 3 weeks before we actually get the medication into our facility from ViiV. Okay, in terms of your office, the staff needs to know how to do a Z-track injection. So that's something they were taught, but it's not a commonly used injection. ViiV has people who will come to your clinic and train your staff. They also have a video online in order to, your staff can watch that and train it. In our particular instance, we trained the staff, and then we had them practice, and then we signed them off to make sure, so they weren't all signed off immediately. We made sure that they knew what they were doing. Okay, the other thing is that in our case, when they come in for an injection every 2 months, every 4 months, they see a provider and get their injection. 2 months later, they come in for an injection and labs. So in some cases, they might have a lab that we have LabCorp in our office. If their insurance will cover LabCorp, they can get their labs that day and they can get their injection. However, if they have Quest or ABC labs, in other words, that's up to their insurance company, they need to have their labs done before they come. So the staff is trained to verify that the patient has gotten their labs before they get their injection. We don't want them getting the injection and then never getting that follow-up lab. So we do have the staff trained to make sure that they've had the labs before they get their injection. Okay, if someone is on oral PrEP, like I mentioned, it's not going to start right away. It's might be a week or two, or maybe even longer, depending on the insurance. So we continue them on the oral PrEP until the day prior to the injection. Okay, just keep taking your pills. If they're not on oral PrEP, they do have to have an HIV test within 7 days. And we either start them on oral PrEP until it comes in. In some cases, patients just don't want to be on pills, in which case we advise them to abstain from unprotected sex until the injection date. Okay, the practical considerations. If your patient has Medi-Cal, once you can establish an agreement for the specialty pharmacy where your patient will be, where you will be getting the Apretude from, they're the easiest ones. You need to get an authorization for the injection, which takes about 2 weeks. In our case, we have a pharmacy very close to us, within walking distance. It used to be right next door. In other words, you left one door and you went to the next door, and that was them. But we just moved across the street, so now we have to go across the street. But they are a specialty pharmacy. I send the prescription there. We go pick it up, usually about Thursday of the previous week for the following week's appointments. And we have it in stock in our office at that point. So if you don't have a specialty pharmacy that you have an arrangement with, you need to find one that can supply your Apretude for your office and make some sort of arrangement, whether they deliver it the previous week, whether you go pick it up, whatever it is. And then you, all of my Medi-Cal prescriptions go to that pharmacy. It's Medical Mall Pharmacy in Long Beach. So that's pretty much settled. Those are actually the easiest patients that we have in terms of implementation. Okay, then you also have uninsured patients. So uninsured patients can be enrolled into the ViiV Patient Assistant Program. And I have the form right on the right. It's a 4-page form. Either your staff, or if you have a PrEP navigator who will fill that out and fax it in. It takes about 2 weeks for it to be processed. They will send the prescription to usually Alliance RX Walgreens, and Alliance will call you to verify when you want it delivered. You could either wait for them to call. They used to call, but at this point, the PrEP navigator in the office calls them just to make sure that they're going to send that prescription. And I usually try and make sure that it's about a week or two before the patient's coming in, so that you're not waiting on a Wednesday morning for the patient who's coming in Wednesday afternoon. We like to make sure it's in the office. If someone is insured, the ViiV Connect will cover the copay if the patient makes less than 5 times the poverty rate, which I believe is around 72,500, somewhere in there. So if they make less than 5 times the poverty rate, which, like I mentioned, is in the $72,000 a year for a family of one, ViiV Connect will pay the copay on the medication. So this is for patients who are insured. There's no copay for Medi-Cal. There's no patients for the patient assistance program. But for those who are insured, if they have a copay, ViiV Connect, ViiV will pay for it. Okay, if they're less than 72,000 a year. Okay, so we have to determine also if the insurance will cover Apretude under a medical or a pharmacy benefit, or under buy and bill. And different pharmacy or different insurance companies have their own designation on how they're going to pay for them. And I'll get to that in a minute. Okay. The other thing to take into consideration is that there's a specialty pharmacy that is associated with that insurance company. And very early on, we made the mistake. I don't remember what company it was. I'll just say Blue Cross. It's an easy thing to say. One patient, they said, send it to a certain pharmacy in Arizona. We had another patient, Blue Cross. I sent the prescription to that pharmacy in Arizona. They couldn't cover it. They said they weren't connected with that particular insurance company. I had to send it to Pittsburgh. Okay, so you need to find out what specialty pharmacy is associated with that particular insurance coverage. And there's going to be two ways to do that, and I will get to that in a second. You can utilize the ViiV. They have she's a field reimbursement specialist. And when we were running into a lot of brick walls when we first started this, when we finally started to work with the ViiV field reimbursement specialist, that's when doors started to open. So the ViiV representative will find out where you need to send the prescription in order to for that particular insurance company. So even though they may or may not be covered by ViiV Connect, we have them fill out the form and we fax that to her, and she can go from there and determine what pharmacy it needs to go to. Okay, so for commercial insurance, they might have a pharmacy benefit, in which case you can send it to a pharmacy, and so Medi-Cal, etc. We send that straight to Medical Mall, our pharmacy next door, and it's not a process. If the insurance company has a medical benefit, that is the ones that I was just talking about. There's a specialty pharmacy who they have decided they want to work with. Some of the specialty pharmacies are Genoa Specialty Pharmacy, Accredo, CVS Specialty, or Alliance RX Walgreens. And that's where you either have to call the insurance company and find out where they want that prescription to go, or you can just fax it off to the field reimbursement specialist, and they can get back to you and tell you exactly what you need in order to get that medication into your office. Okay, there's also buy and bill. And in that particular case, the clinic uses your own money in order to buy the PrEP, and then you submit the claim to the insurance company for reimbursement. Our particular care center does not do that, but that is another option that your clinic does have an option to do. So that would be if the insurance company says, we only do buy and bill, period. Okay. Let's see. Okay, like I mentioned, they will call you and ask you, where do you want this sent? We don't send it to the patient. We send it to the clinic, because I want to make sure it's in the office, and I want to make sure that the patient doesn't forget to put it in their car the day that they have a prescription. So we always have it arranged to be sent to our clinic. Okay, some of the pharmacies ship automatically, which makes it really convenient. You don't have to follow up. But this is something where if you're going to be doing a high volume, you need to have someone in your office who's monitoring which ones need to be called, which ones don't need to be called, and checks the week before to make sure that you have the medication in stock. And if it's not in stock, they know exactly who needs to be called in order to get it. And like I mentioned, some pharmacies, you have to contact them every 2 months in order to arrange the shipment. And like I mentioned, we try and make the shipment come 2 weeks before the date. Okay. And for Medi-Cal patients, that's like I mentioned, we use Medical Mall. We just walk down the street, get the medication, bring it back. But you need to make sort of arrangement with a specialty pharmacy so that, either they deliver or you go get it yourself. Okay, labs have to be completed within 7 days of the injection. However, if someone is if they have LabCorp, which we have in our office, and they're on time, everything's going smoothly, we allow them to get the labs on the same day that they get the injection. It makes it very easy for the patient. They have one visit, they get the labs, they get the injection. However, some insurance companies require the patient to get their labs at either Quest or ABC, which we don't have. Some of them require appointments, some of them don't. They do walk-ins. So you need to emphasize with the patient that they need to take responsibility for that. I usually print the labs for the patient so that if the patient gets to the site and they can't find it, et cetera, they have a copy of what it is they need to get done. And then in our office, we do require that the labs need to be completed prior to the injection appointment. It could be at 1 o'clock and they have an appointment with us at 2. That's fine, okay? But they have to have labs within 7 days. It can be 7 days after, but that's up to you to decide. Okay, so review. Address the concerns and the appropriateness of long-acting injectable for that particular patient. Explain the lead time for starting long-acting injectable, and then solidify the workflow with the patient. You're going to get a copy of your labs. You need to make an appointment with Quest Labs on X day within 7 days, and then you need to come in for your appointment. And I let them know it's supposed to be done every 8 weeks. And yes, we can give it to you 7 days late. And technically you can give it up to a month late. However, the longer you wait between injections, your coverage is going down. So keep your 2-month appointments so that your coverage stays. In other words, your protection stays high. Okay, as far as the clinic goes, you need to have someone who's monitoring the shipments and making sure that they are in stock before the patient comes. And you give that plenty of time so that if somebody needs to go do something or contact someone, it can be done. Okay, you need to monitor that the provider visits at 4 months and injections at 2 months. And I will admit we got to where we started to realize that patients were getting an appointment for an injection, 2 months later an injection, 2 months later in an injection, and they weren't getting their STI visits and they weren't getting their provider visits. So you really need to monitor that they're getting their every 4 months they're seeing the provider and they're getting STI checks, and every 2 months they're getting, or 2 months later they get an injection. So we chose to train the injecting staff to verify that labs were performed prior to the injection. If they weren't, they call the provider. The provider can make a decision, discuss with the patient, go from there. And the people who schedule the appointments, that's why we were having a little problem where they were being scheduled for injections. They need to be informed of the scheduling needs, that every 4 months they get an injection and a visit with the provider, and 2 months later, in alternate months, it's the injection only. So that staff needs to be trained on that. Oh, let's see. And then ViiV contacts for assistance. So your territory account manager is the one who can answer questions in terms of if you do need somebody to come into the office and train the staff on doing the Z-tracks, they can arrange that. They can also offer you different information for the patients, as well as more information for the provider. There's the medical science liaison. So if you do have any technical questions, they do have a medical science liaison who can address those questions. And then they have the field reimbursement specialist, which in the case of Apritude, we utilize much more with our private insurance patients. And if you do have other questions, apritudehcp.com is a good source for information. And so the last thing is, what are the questions?
Thank you very much, Christine. So Elena, do you want to open up and we can go to some questions?
Yes, sounds good. All right. So I will say we've had a lot of activity in the Q&A box. So if you haven't been in there yet as an attendee, I invite you to take a look at all the questions and responses that are already in there. Thank you so much for your presentation, Christine. One question we got for you is, so theoretically speaking, if someone makes $80,000 plus per year, does that mean they're going to have to pay a $7,000 copayment?
So it depends on their insurance. It depends on what their insurance, what their copay is. If 7,000 is probably a little much. Let's see. I can't think of some copays off the top of my head. In other words, if it's covered, their insurance, generally they're 80-20, and it would cover everything but 20%. It depends on the patient's insurance. So the patient would be responsible for the copay.
Got it. Thank you. I think we got perspectives from one or two of the other presenters on this already, but this question came in for you as well. Do you use an oral lead-in, especially when insurance verification takes weeks? Also, how do you handle the discontinuation? Are clients willing/adherent with oral PrEP for the recommended year?
Okay, so in terms of the oral lead-in, initially we were starting with the oral lead-in, but you don't know how many times I would walk into the room with my little oral bottle and they'd say, wait a minute, I thought I was going to get a shot. I just want a shot. So I tell them they do have the option of the oral lead-in, but most of them they just want the shot. The vast majority of the patients that we have going on the long-acting injectable are people who are on PrEP already. So actually, I imagine I could have changed them over to the Vocabria, but I tell them to just keep taking their Descovy or their Truvada, whatever it happens to be that they're taking. As for the new people, like I mentioned, I do tell them to go ahead and take pills. I usually do just send them Descovy or Truvada, but that's actually a legitimate point that I could have them send them the Vocabria in order to get started on Vocabria. It's just something that really didn't come into my mind. And also, I'm also thinking it's probably going to be about 2 weeks. Yeah, Vocabria definitely would be a choice that if somebody is not on PrEP, they could get started on Vocabria. Yeah, I don't think anybody has wanted to start on the pills first. They're just ready to go, but it is definitely an option. And then the other thing is discontinuing. You make that's also a very, very good point that I probably should have brought up when we go into the implementation, is that counseling the patients that their coverage for the injectable is going to decrease slowly over time, slower over time than the oral, so that it also depends on what their situation is. Are they now in a monogamous relationship and no longer need it? Or it just wasn't working for them, in which case they do need to be counseled that they should stay on an oral PrEP in order to continue and remain protected.
Great, thank you so much. Ron, back over to you.
Thank you very much.